Sanjay Kumar Daulat Thakur, the co-chairperson, Dr. Sandeepan Bandyopadhyay, and myself, I'm the moderator, Dr. Swati Agarwal. Yeah, the first presenter, Dr. Shomya, are you here? Please come. In my list, it's showing like this. And one more. Dr. Ananya Hota. Dr. Ananya, are you here? The next speaker, Dr. Shomya. She's going to present on More Than Just a Red Eye, a case series of estrous ovis ocular infestation. Is Dr. Meeta Shah here? Dr. Meeta Shah, madam, please come forward.
Good afternoon, everyone. Myself, Dr. Akanksha Rangari. I am presenting my paper on pterygium surgery by conjunctival autograft with autologous blood fixation versus fibrin glue. Pterygium, it is a degenerative condition of subconjunctival tissue which proliferates as vascularized granulation tissue to invade the cornea. The prevalence varies from 0.3 to 29%. It is managed conservatively unless it is progressing toward the pupillary area. Surgical removal is the treatment of choice, but recurrence is the main problem here. Bare scleral excision alone is associated with recurrence rate of about 30 to 70%. Conjunctival autografting after excision is associated with lower recurrence rate. This study has been conducted to compare the efficacy of fibrin glue as compared to autologous blood in attaching the autograft. Materials and method. This is a retrospective comparative case series of patients with primary nasal pterygium who underwent excision from January to June 2023 in Tertiary Care Hospital of Surat. Based on the technique used to fix the graft, the groups were divided into two of 20 each patients. In group 1, the graft was fixed with autologous blood, and in group 2, it was fixed with fibrin. Surgical procedure. All the surgeries were performed under local anesthesia. Pterygium excision was done, and conjunctival autograft was taken from the superobulbar conjunctiva. In group 1, a small conjunctival blood vessel was nicked with 26 gauge needle, and blood was allowed to ooze over the bare sclera, and graft was placed over it, and then we have to wait until 10 minutes to fix the graft. In group 2, we use fibrin glue to fix the graft. All the patients were then followed up until 6 months. During each visit, we see for pain, any foreign body sensations, discomfort or any complication, and status of the graft. These were the post-op images of patients operated with using autologous blood and fibrin glue. Results. In group 1, there were 12 males and 8 females, and group 2, there were 13 male and 7 females. The average surgical time for group 1 was 45.2 minutes, and for group 2 it was 37.5. Pain and foreign body sensations were seen in both the groups, but they were reduced within a week. Graft retraction was seen only in one case of group 1, not seen in any case of group 2. All the patients were evaluated for signs of recurrence at the end of 6 months. No recurrence has been seen in both the groups. These were the table showing post-operative evaluation from day 1 to until 6 months. Discussion. The standard treatment of pterygium excision is conjunctival autograft. However, outcome is compromised by recurrence and complications. The use of conjunctival autograft was described by Kenyon et al. In 1985. The recurrence rate has been dropped from 89 to 2%. Pan et al. In their meta-analysis, they supported the superiority of glue over suture. Autologous blood, it is a good alternative as compared to fibrin. D. Vital in the study, they have shown that 15 eyes, they shown that autologous blood is safer and comparable results to suture and glue. Conclusion, both the techniques used to secure the conjunctival autografts were effective in reducing the recurrence rate. Fibrin glue is most effective method for fixating the graft with least surgical time and postoperative discomfort, but high cost and availability was an issue. Autologous blood, it is an effective alternative which is easily available and economical as compared to fibrin glue. Thank you. So we have seen on post-op day 1, then day 3, day 7, then on day 14, and
No,
one.
sir's question is how many patients did you see the graft was lost?
Sir, only one patient was there with lost graft in autologous blood, not in case of fibrin glue. There was no patient in case of fibrin glue.
How did you determine the sample size?
Sir, sir,
You have taken only 20 patients.
yes, sir.
Is it enough for statistical analysis?
No, sir.
So you could have increased the number of patients. And did you do any randomization?
Yes, sir, we randomly divide.
Which procedure did you use for randomization?
So we give sequence to the patient, first patient for autologous blood.
That's not the scientific way. And this is already a established procedure, autologous blood with pterygium surgery.
Yes, sir.
So what's new in your paper? This study has been done several times. What's new from your study?
So it was not done in our GMC Surat.
Maybe.
That's why we have done it.
Level, anything new you want to add?
No, sir. Thank you.
There's a spelling mistake. Conjunctival spelling is wrong. Please don't do that.
You should always take care for next time. Thank you.
Yes, sir. Yes. Sorry, sir.
Anyways, well done, Kanchan. Next speaker, Dr. Ramya Yanti. Dr. Ramya, please. Would request all the speakers to load their presentations with the AV team at least if possible.
Dr. Ramya, a study on effect of artificial tears of different viscosity and keratometry readings in cataract patients. There are no financial interests or relationships to disclose in this study. Introduction. Artificial tears are lubricating eye drops used to relieve dryness and irritation of the ocular surface. They are used to supplement a patient's naturally produced tears and increase eye lubrication by mimicking characteristics of tear film. Aim was to study the effect of high viscosity and low viscosity artificial tears on K readings in cataract patients. Objectives to assess the effect on high viscosity artificial tears on K readings in cataract patients and to assess the effect of low viscosity artificial tears on K readings in cataract patients. Materials and methods. Study type, it's observational study. Sample size 90 patients divided into 3 groups. Group A 30 patients of high viscosity and group B 30 patients of low viscosity and another group is control group of 30 patients. Sampling method is a convenient sampling of duration 2 months. Study setting was done in Department of Ophthalmology, Tertiary Care Center. Methodology was to obtain Institutional Research Committee and Ethics Committee approval to conduct the study by submitting the protocol. Written informed consent was taken and to record the patient demographic details. After a comprehensive ophthalmic evaluation, all the patients are undergone this evaluation. Keratometry readings K1, K2 of both eyes were noted before installation of artificial tears and after 5 minutes of installation of artificial tears, and changes in keratometric readings are noted. Study tools for Snellen's chart, refraction room, slit lamp examination, ARK for measuring the keratometry values. Inclusion criteria: patients with bilateral cataract without any ocular surface diseases were included. Exclusion criteria: eyes with corneal pathology, history of trauma and ocular surgery, corneal or conjunctival infections are excluded. The statistical analysis: the collected data was entered in a Microsoft Excel and analyzed using SPSS software. Statistical analysis was done using paid t-test and ANOVA test. P-value less than 0.05 was considered statistically significant. In the paid sample t-test, within the groups, the p-value has been less than 0.05, hence it shows it's statistically significant. In the ANOVA test, between the groups, the p-value is less than 0.05, hence it's statistically significant. Coming to the discussion, a present study done in a tertiary care center, a study on effect of artificial tears of different viscosity and keratometry readings in cataract patients. The sample size was 90 patients. The conclusion is tear film stabilizing eye drops prior to keratometry measurements influenced care readings significantly. The higher the viscosity of the eye drops, the stronger the influence and the longer its persistence. Another study, Epitropoulos et al. Has been done a study on effect of osmolarity on repeatability of keratometry for cataract surgery planning. A sample size was hyperosmolar group of 100 eyes of 50 subjects and normal group 50 eyes of 25 subjects has taken. The conclusion was statistically significantly more subjects with hyperosmolar tears showed poor repeatability of K values. A shared R has done a study on optimizing biometry for best outcomes in cataract surgery. Sample size was 28 patients. The conclusion is within modern optical biometry for majority of patients informed formula choice and IOL constant optimization outcomes. The conclusion is tear film stabilizing eye drops prior to keratometry measurements influenced K readings significantly. The higher the viscosity of the eye drops, the stronger the influence and the longer its persistence. Thank you.
What is new about this study? Because this is a proven fact that one should not be giving any form of eye drop. It should always be done on a virgin eye once the patient is coming for cataract surgery. So K reading is always taken prior to it. So is there any new information you would like to give?
But ma'am, without installation of, there is difference between installation of eye drops on K readings and before installation of eye drops of K readings. For a cataract surgery, the calculating the IOL power is very crucial in the cataract surgery patient. So there is difference in K1, K2 values before and after the installation of eye drops.
Yes, that is what. There's nothing new information in this. That is why if patient is coming with dry eye and if maybe the Myers are distorted for K readings, then we, give lubricating dry eye drops. We ask the patient to come another day. So that is the followed protocols everywhere. So any new information this is giving?
No, no ma'am.
Okay.
In this study, we have instilled the eye drops and we have taken the readings after 5 minutes of installation of eye drops.
What is your recommendation based on your study?
Before, prior to 1 day, thank you.
Hello, yeah. Dr. Sneha Shah, are you here? Dr. Sneha, please load your presentation. And next we would be having Dr. Rishabh Narula. Dr. Narula, are you here?
2786 वाला देखो ना 2786 Good evening, everyone. I will be discussing about vernal keratoconjunctivitis and supratarsal steroid as a treatment modality. No financial disclosures. Atopic ocular disease can be classified as seasonal, perennial, vernal, atopic, and giant papillary conjunctivitis. VKC is one of the chronic vision-threatening allergic disease. Mast cell activation is implicated in disease. However, inflammatory cell-mediated immunopathologic changes drive development of vision loss. Corneal scar, irregular astigmatism, keratoconus, cataract, and glaucoma are causes of decreased visual acuity. Study design, it is a retrospective study of 1 year period including 31 eyes of 20 patients with severe recalcitrant VKC. Purpose of this study is to evaluate use of supratarsal steroid in severe recalcitrant VKC. Method, patients with giant papillae, gelatinous limbal infiltrates, epitheliopathy, shield ulcer, along with history of recurrence and resistance to conventional topical anti-allergic agents were included, who were given supratarsal injection of 20 mg triamcinolone acetonide. Results, patients were evaluated at interval of 15 days, 3 months and 6 months. 70% of patients were between the age of 11 to 20 years, while 10% of patients were between 0 to 10 years, and 20% of patients were between 21 to 30 years of age. 95% of patients were males, while only 5% of patients were females. 50% of patients were already on treatment from outside hospital, while 50% of patients were started on treatment in our hospital. 10% of patients had history of asthma. 55% of patients received injection in both eye, while 45% of patients received injection only in one eye. 100% of patients had giant papillae with epitheliopathy, 35% of patients had limbitis, and 55% of patients had shield ulcer. In 100% of patients, allergy symptoms and signs were significantly improved on 15th day post-injection. IOP rise was seen in 5% of patients on 15th day, 3 months and 6 months. Raised CDR was seen in 5% of patients by 3rd month and 10% of patients in 6th month. 25% of patients needed repeat injection by 1 year, 15% needed by 2nd year, and 5% by 3rd year. 15% of total VKC patients developed keratoconus in future. Conclusion, satisfactory results were obtained and injections were well tolerated by patient. It may therefore constitute a safe option for severe challenging cases. While full disease remission was not achieved, significant improvement was found in ocular symptoms and signs with reduction in frequency of acute recurrences. Therefore, timely intervention translates to preservation of vision by preventing permanent complications. Thank you.
Okay, thank you, Dr. Sneha. That was a nice presentation. And we would invite the next speaker, Dr. Rishabh Narula.
Good evening, everyone. I'll be talking about scleritis. I'll be presenting my case on scleritis, clinico-etiological profile, and response to treatment. Scleritis is a painful, chronic, destructive, inflammatory disease of the sclera, can lead to vision-threatening complications, often presenting in 4th to 6th decade of life, can have an immune-mediated or an infective etiology. Immune-mediated type being associated with RA most commonly, and is the first manifestation. Scleritis is the first manifestation in up to 59% patients with connective tissue disorders. It has been classified by Watson, as we all know, and shown on the screen. Topical corticosteroids and oral NSAIDs are the first line of treatment, with immunosuppressants and biologics being kicked in for refractory and unresponsive cases. Median time to resolution after starting treatment is longer for infectious scleritis as compared to the autoimmune type, and if not treated adequately can result in visual loss by spread to contiguous ocular structures. The aim of our paper was to describe the clinico-etiological profile of patients with scleritis and their response to treatment regimens in a tertiary hospital. 11 patients diagnosed with scleritis with or without pre-existing systemic associations presenting to the hospital were included in our retrospective study, which was conducted from July 2022 to 23. Patient demographics, ocular findings, systemic associations, and treatment given, and also the outcome till the last follow-up was recorded. What we saw was the mean age at presentation was approximately 49 years with a female predilection, mostly unilateral, and the etiology was more likely immune mediated in all the patients. And the mean duration of disease till the time of follow-up was 4.5 years for systemic disease and 1.3 years for ocular disease. Pertinent to mention, 2 patients didn't have any systemic association and presented as scleritis as the first presenting symptom. The incidence of various subtypes was noted, and nodular anterior scleritis was found out to be most common, followed by diffuse anterior type, and we had 1 case each of necrotizing scleritis with inflammation, scleromalacia, and posterior scleritis. Systemic association was most common with connective tissue diseases, and 1/4 patients had association with vasculitis. Treatment regimen was started on a step-up approach, and immunosuppressants or biologics, which are the highest level, were actually required for all immune-mediated inflammations. Surgical intervention with scleral patch graft was required in 1 patient who presented with scleromalacia perforans. Infectious scleritis was treated with systemic corticosteroids, plus minus posterior subterranean and triamcinolone under antimicrobial cover. The various systemic agents used, systemic corticosteroids for all patients, antimetabolites like methotrexate for most of the patients, and then cyclophosphamide, and monoclonal antibodies were required for 2 patients. This image here shows the patient with the scleromalacia perforans for which scleral patch grafting was done. Outcomes were generally good. Patients responded well with complete resolution in 10 patients, but there were recurrences of up to 8 episodes during the time of follow-ups in 6 patients. And 6 patients developed complications, cataract being most common, which led to deterioration in vision in 3 patients. There was improvement in vision in 4 patients, and maintained vision was seen in 4 patients. Visual acuity impairment at presentation was comparable to that at follow-up, but 1 patient who was not very compliant to treatment worsened to blindness. So our study basically showed features very similar to the existing data, but also has shown a positive response, like supportive evidence for immunomodulators that can help in the progressive relapses. But the limitation being a small sample size, which may not be a true indicator for disease pattern. Management of scleritis requires a multidisciplinary approach, and careful screening for systemic diseases is required in all cases of scleritis. Prompt initiation of treatment, use of newer agents may help in improving survival and delaying recurrence in refractory cases. Thank you.
Thank you. Hello. Thank you, Dr. Narula. Thank you, my colleagues, for being in this session. And thank you all the listeners. Thank you.
I thank all the chairpersons and the conveners and all the presenters. Everyone did fabulous, and I think they were take-home points for the presenters as well. And thank you, everyone.